नाही. तर
सर आवाज येतो सर?
हॅलो,
तुमचा आवाज नाही येतो सर.
हो येतोय सर.
आमचा येतोय तुम्हाला?
हो येतोय मॅडम.
हा ठीक आहे, ओके. Yes.
Madam, good afternoon. Shall we start?
हो मॅडम हो 1-2 मिनिट बाकी आहेत मॅडम 3 वाजायला 2च मिनिट ते लोक जॉईन होत आहेत 1-2च मिनिट Okay, so all the physicians will join eventually. We will be waiting for them. So today, on behalf of Government Medical College Aurangabad and Physicians Association Aurangabad, I welcome you all for this session on management of hepatitis B and C. Today, it is my pleasure to introduce our efficient Dean, Dr. Varsha Rote, Madam. You all are aware of the huge pasaras of Government Medical College Aurangabad, and she is handling everything efficiently since last 4-5 months. I request her to say a few words and inaugurate this session today. Madam, over to you.
A very good afternoon to everyone. Am I audible, Madam? Bhattacharya, Madam?
Yes, Madam, audible.
Great. So, good afternoon all, and it's my privilege speaking to the eminent physicians of this society, of this city. And I congratulate the Physicians Association, Dr. Patne, and Department of Medicine, GMC Aurangabad, Dr. Bhattacharya, for having this wonderful awareness program. What I know about hepatitis is marking this occasion is hepatitis can be preventable provided the awareness has to be there, because the morbidity of this disease is very, very high, and with few preventive measures and avoiding the risk factors, we can avoid those grave complications like chronic liver failure, hepatitis, or hepatocellular carcinoma. So, and what I learned from Dr. Bhattacharya that the National Hepatitis Control Program is aiming towards eradication of this deadly disease by 2030. So many such awareness programs are needed, and this is one of it, and I'm extremely happy and I appreciate you all for this. And ma'am, I wish you all the best. And I declare that this program is on for you. All the best. Thank you so much.
Thank you, madam. Thank you so much. Now I request Dr. Patne sir, who is our enthusiastic president of our prestigious Institute Physicians Association of Aurangabad. I request him to say a few words about today's session. Sir, over to you. Patne sir, ऐकायला येतंय? पाटणे सर, पाटणे सर ऐकायला येतंय?
हो येतंय मॅडम.
Okay, Patne sir, please say a few words about today's session. Sir is connected, but I don't know whether he is able to hear. Sir, please unmute. Patne sir, please unmute yourself.
Yeah, now I'm unmuted.
Please say a few words, sir.
Yeah, thank you, madam, for taking this initiative and organizing, because this is a topic which is really neglected in the medical curriculum and is a raging medical scourge. Hepatitis B, as I understand, and hepatitis C is highly underrated, but a major problem, not only in urban areas, but also in rural places, where now with the advent of transfusion and other blood-related practices, it is spreading wildly and is undiagnosed most of the times. So I really thank you. Hello, madam, can you get me? Hello.
You can continue. Yes, sir, you can continue.
Yeah, madam. So it's really a great boon, great help to all my physician friends for taking a topic which is clinically relevant and very important for us from management point of view. Both hepatitis B and hepatitis C is undiagnosed, underdiagnosed, and a raging malady in not only urban areas but also in rural areas. I thank you all. I thank the Dean GMC and Bhattacharya madam in person for taking this initiative. Please go ahead, madam.
Thank you so much, sir. Thank you. So coming to today's session, I'll share my presentation first. So we all are in a post-COVID recovery phase and we are trying to live our normal routine life. But as we all have seen that at national level, India has really done well in management of COVID. But this COVID has taught us many multiple lessons, and one of this lesson is poor infrastructure and poor healthcare facilities at root level. And to avoid this, we have multiple national level programs. And as you all know that we have one national AIDS control organization program, that is NSCP. And under this program, under the network of ART centers, we have achieved all the objectives of controlling HIV and AIDS. And now this national hepatitis control program has been started by Ministry of Health and Family Welfare in 2018. And since then, the trainings were undertaken at different levels, starting from medical colleges as nodal centers, and then the program is now under rollout. So, next slide. Okay, so on 28th July, which is World Hepatitis Day, this program was launched in 2018, and the aim of this program was to deal with this hepatitis and wide elimination of hepatitis C, basically, because we know that hepatitis C can be cured, and if patient takes properly and is detected. So elimination of hepatitis B by 2030 is very important objective of this. Another is to achieve significant reduction in infected population of hepatitis B and C, and also decrease morbidity and mortality related to hepatitis C virus infections. Next slide. Yeah. So this has started with medical colleges and tertiary care centers, and all over Maharashtra. All medical colleges are nodal centers. They are connected to district hospitals and sub-district hospitals, and testing for hepatitis B, prevention strategies, management strategies, everything is being available at free of cost to every patient at root level. There are few objectives which we have proposed under Department of Medicine and Medical College Aurangabad. First and foremost is to increase community awareness of Aurangabad population, that we need to know status of hepatitis B infection in the community, so that we can find them out, we can treat them and monitor them appropriately. So to address this, we need to keep proper data, and for this we have started with one portal, that is a national portal, and on this national portal we will be uploading all cases. Now we have uploaded around 130 cases on national portal since last 3 months, and another is vaccination. Vaccination program is important to prevent further progression of this disease and mortality and morbidity. Mother to child transmission is known with hepatitis B and C. So we are screening every ANC patient and starting them on treatment if at all required. So the strategy what will be followed in COVID: trace, treat, and monitor. So I request everyone to please mute your mics. So we will be testing these patients, tracing them, calling them for treatment initiation, and then we will be monitoring them. So for this, we have a separate staff which is made available. We have medical officers, we have a peer supporter. Peer supporter keeps a follow-up with these patients. Regular follow-up with these patients. So just to revise basics, there are 5 types of viruses, and enterically transmitted hepatitis A and C, and parentally transmitted are hepatitis B, C, and D viruses. And hepatitis A and E outbreak we have seen in 2019 in Shahbazar, Roshan Gate and Collector office area. That time we had almost 50 to 60 patients which had come for hepatitis A and E infection, and that had happened because of poor sanitation and the contaminated water supply from corporation. Major difference between hepatitis A and E is hepatitis A is more common in children, E more common in adults. A is self-limiting. It usually presents at acute hepatitis, and once someone has developed acute hepatitis A infection, they develop lifelong immunity. Vaccination is also available against hepatitis A, but hepatitis E patients, mostly we see hepatitis E infections in pregnant ladies. These patients, they also develop lifelong immunity once they get it. Effective vaccine is available only in China at present. So hepatitis B and hepatitis C, both are, hepatitis B is DNA virus, hepatitis C is RNA virus. Importance of these virions is that these virions have lipid membrane over there as an envelope, and if we wash our hands with soap and water, then it gets dissolved. So whenever we discuss this with our new interns or new batches of students, we always tell them to clean their hands with soap and water so that HIV, HBsAg, HCV, all these viruses can get decontaminated if they are exposed to it. And the same thing should be done in post-exposure prophylaxis. So if someone is exposed to hepatitis B or C viral needle prick injury or some blood, the injury mark or the site should be cleaned with soap and water. So hepatitis B acute infections may not be detected in few cases, but if some develop, we have seen many healthcare workers who died because of acute hepatitis B infections, and it can lead to fulminant hepatitis leading to fatality. So few of these cases, hepatitis B infection remains unnoticed. They become chronic carriers of hepatitis B, then develop chronic hepatitis, cirrhosis, and ultimately hepatocellular carcinoma. So we need to remember this and detect these cases at the earliest. For hepatitis C, usually first infection is unnoticed, and almost 70% of these cases, they become chronic infectious cases. And there is no vaccine available against hepatitis C, but hepatitis B we can definitely prevent. And if we can prevent hepatitis B, we are able to prevent hepatitis D virus also, because hepatitis D is an incomplete RNA virus. It usually is found in those patients who are hepatitis B virally infected. So prevention is better than cure. Vaccination, regarding vaccination, I would like to inform you all that hepatitis B vaccination is made free of cost available at GMC Aurangabad on first floor in the OPD number 125, and anyone from the general population or those patients on hemodialysis or pregnant ladies, they can come and take this vaccine freely. If you all have your healthcare workers working in your hospitals, you can send these workers for vaccination, and the dose the schedule available is 0, 1, and 6 vaccines are available with us. So coming to the today's discussion, I will be discussing treatment or management as per these few questions. I will try to answer this, and the reference for this is National Viral Hepatitis Control Program module, and which is the main author for this is Dr. S.K. Sareen from the ILBS Delhi. So first I will be discussing whether infection is acute or chronic infection. It is patient has chronic hepatitis or liver cirrhosis. If patient does not have cirrhosis, then how patient should be managed? If patient has cirrhosis, how to identify whether patient has compensated or decompensated cirrhosis, and how to treat these patients, and when they should be treated, and lastly, monitoring of these cases. Then I will be just touching upon hepatitis C management, whatever drugs are available with us, and then the special population. So coming to acute versus chronic, as we all do, all those patients coming with prodrome, fever, jaundice, and having abnormal liver function test, hepatitis B is the screening test. And if patient has hepatitis B positive or you have high index of suspicion, IgM for anti-HBC IgM can be done. If it is positive, it suggests that patient has acute infection, and if patient has small size or the shrunken liver associated with encephalopathy and has abnormal prothrombin time along with severe hypoalbuminemia, they are likely to be in acute liver failure. And if these patients have anti-HBC IgM positive, they are in acute fulminant hepatitis. So, how to identify whether it is chronic liver disease or patient has active hepatitis B infection? So, the first and foremost test is hepatitis B surface antigen positive, and if it is positive, it indicates that this virus is there in patient's body, and it usually persists for several years. If anti-HBs is positive, that indicates that patient is immune, and probably those persons who has received vaccine, they have anti-HBs positivity. So if someone, healthcare worker comes to us with hepatitis or healthcare worker comes with a needle prick injury, and vaccinated, we usually ask them to get their anti-HBs titer done. So if anti-HBs titer is more than 10,000, then we say that this patient or healthcare worker is protected and might not need further doses. Another important marker which is to be done in HBsAg positive patients is hepatitis B core antigen and antibody. Now, HCV anti-HBC, I have already told those patients who have IgM anti-hepatitis B core antigen, they have active or acute infection, and that indicates that patient is having viral hepatitis B infection. Now, if hepatitis B envelope antigen is positive, it suggests that patient has high viral load and high infectivity. So when we will be discussing treatment, I will be coming back to this again, HBeAg, because it's a very important marker, especially in those patients who do not have cirrhosis. Because those who have cirrhosis, we need to treat them. Those who do not have cirrhosis, we get their hepatitis B envelope antigen done. If the envelope antigen is positive, that suggests that patient has high viral load, high infectivity, and we will have to treat these cases. If it is associated with high risk of HBV transmission, usually following needle stick injuries and mother to child transmission. So, along with all these markers, another thing is HBV DNA, hepatitis B virus DNA copies. That all these tests are available with us at present. Hepatitis B envelope antigen is not there, but rest of the tests all are done with us. HBV DNA levels, that is viral load, it suggests that patient is having HBV replication, or the virus is replicating in patient's body. So the number of viruses in the body is important to begin with the treatment. So once we have a hepatitis B surface antigen positive patient with us, we differentiate whether patient has acute infection, anti-HBM positive, IgM anti-HBC positive, suggests acute infection, chronic infection, if patient does not have prodrome or acute manifestations and previous history of exposure is there. So another question comes is, if patient has chronic hepatitis B, how to differentiate whether this patient has liver cirrhosis or not? So as per the natural history of chronic hepatitis B, depending upon the immune response of patient, that we have very well now known with COVID. So in chronic hepatitis B infection, patient might develop an immune tolerant phase or immune active phase. If patient has good immune response, these patients, they come, they have immune control phase, and all the viral load is suppressed. Their immunity is taking care of this viral control or viral suppression. So few of these cases, they get immune clearance and can get cured also. But few of these cases, depending upon the immune suppression, if they develop some condition like co-HIV infection or malignancy, they may develop reactivation of this infection and worsen, and mortality and mortality is high in these patients. So once we have diagnosed that patient has chronic HBV infection, we need to find out which stage this patient is in. Is patient's immunity or immune response is functioning well? Patient is under control or is not under control? So what are the things which are required for this? First and foremost is HBV DNA copies. Depending upon the viral load, we will be able to know how many viruses are there in the body. Then we will do hepatitis B envelope antigen. If envelope antigen is positive, that suggests that patient has actively replicating viruses, and this patient should be treated at the earliest. Those patients who have immune clearance, usually their liver function tests are normal, or they have mild to moderate raise, their viral load is low, HBe Ag might be negative, they usually have anti-HBe positive because their immune response is good, and they do not need any treatment. So once patient has chronic hepatitis B or chronic hepatitis infection, as per the immune response, few of these cases, they may develop liver cirrhosis, and further, if the immune response worsens, then hepatocellular carcinoma is very common nowadays. We see many cases of HCC, and cause is either hepatitis B or hepatitis C infection. All these lead to liver cirrhosis, and severity of liver cirrhosis depending upon the stage of that fibrosis. Patient develops splenomegaly, pancytopenia, esophageal varices, or one of the non-invasive indicator is APRI. So esophageal varices, gastric varices, and presence of ascites is very important, because those patients who have all these decompensated signs or presence of all these complications, these patients need to be treated whenever they are diagnosed. To find out severity, there are two bedside tests. One is child poop score. It is our protocol in the our wards that every patient who is coming with liver disease, the child poop score is done, and if patient has grade 3 or grade 4 hepatic encephalopathy, ascites, bilirubin more than 3, albumin less than 2.8, and deranged prothrombin time, INR more than 2.3, it suggests that patient has decompensated cirrhosis. It is very important to understand this, because treatment is based on this basic information. So the fibroscan is one of the non-invasive tests along with APRI. I will be going to APRI, but the fibroscan, as per Metavir staging system, different stages are done on fibroscan. If it is F0, there is no fibrosis. F1, portal fibrosis without septa. F2, portal fibrosis with septa. F3 is numerous septa without cirrhosis, and F4 is cirrhosis. But this is now available at many places. Many radiologists have this fibroscan, but it is very costly, and it is beyond the reach of our common patients. So we have another very important bedside test which gives us presence of liver cirrhosis, that is APRI. APRI is AST or SGPT to platelet ratio, and if you put APRI in the Google search, APRI and liver cirrhosis, you will get this formula. This is a calculator which is available online, and you just have to put your blood levels of your patient, and if APRI score is more than 2, it suggests specificity of 91% whether liver cirrhosis is there or not. So these are few things which need to understand. So now we have seen that patient has acute infection. These are 3 stages of acute infection. Chronic hepatitis B. Now we want to know whether the cirrhosis is compensated or decompensated. I have already explained it, but definition of decompensation is total bilirubin more than 2.5 of upper normal limit, presence of encephalopathy, and presence of ascites, or Child-Pugh score of 3 suggests decompensation. Now, when to treat and whether to treat or not if there is no cirrhosis. So, when there is no cirrhosis, first important thing what we should do is HBV DNA copies. If HBV DNA copies are very high and HBeAg is positive, that suggests that actively replicating virus is there, these patients need to be started on treatment. But if HBeAg is negative and liver function tests are normal, non-cirrhotic patient do not need any treatment. So when to treat? First we do pre-assessment, all the basic things which I covered along with APRI. APRI is very important test because to decide whether this patient should be treated or not. APRI more than 2 suggests liver cirrhosis, and then if this patient who has APRI more than 2 has ascites or encephalopathy or variceal bleed, this patient should be considered as having decompensated cirrhosis. So coming to the summary recommendations of this treatment, what we have done, we have a separate OPD for hepatitis B and hepatitis C patients. In this OPD, we have kept these printouts handy, and all the patients who are coming HbA1c positive, we have a peer supporter who trace these patients. We get these patients APRI, HGPT and liver ultrasonography done, and once all these tests are available, we evaluate these patients whether this patient needs treatment or not. So our patient, if patient has come in the OPD with hepatitis B surface antigen positive, we need to find out whether this patient has fibrosis or not, and patient's age. If patient's age is more than 60, patient has cirrhosis, APRI is more than 2, irrespective of age, HGPT or hepatitis B envelope antigen or DNA copies, patient should be started on treatment. If patient is HBeAg negative, no treatment is required, but patient is hepatitis B surface antigen positive, patient do not have liver cirrhosis, patient has normal liver function test, HBV viral DNA copies or viral load is less than 2000, patient should not be started on treatment. This patient should be followed up regularly every 3 months if HGPT is abnormal. If everything is normal, patient should be followed up every yearly and viral load should be repeated. Now, if patient does not have liver cirrhosis but has persistently elevated HGPT, so whenever a patient comes to us, we look for previous HGPT done and write their previous HGPT and then find out the pattern of this HGPT. If HGPT is increasing over months or years, we consider that patient as persistently elevated HGPT, and if viral load is more than 20,000 of these patients, and particularly those patients who have age more than 30, they should be started on treatment. If these patients, they have viral load of less than 20,000, they should be called after 3 months, HGPT levels should be done, hepatitis B envelope antigen should be tested, and if their viral load levels are between 2000 to 20,000, Then hepatitis B envelope antigen should be done. If envelope antigen is positive, then depending upon the APRI, if APRI is more than 2, this patient should be started on treatment. So what you should remember is we are keeping these printouts with in our OPD so that we write name of that patient on this printout and then screen patient accordingly. So we just tick on whatever is patient having HBAG positive, viral load between 2000 to 20,000, what should be done, and depending upon the fibrosis, we start these patients on treatment. So HBeAg suggests that this patient has actively replicating viruses in the body, and if such patient has high viral load or patient has viral load less than 20% but has elevated HCPT, this patient should be started on HBsAg drugs. So what are the drugs available? Since 1992, we have drugs available for hepatitis B and infection, interferon alpha 2B. Many of healthcare workers were on this drug because that time we did not have any other drug. We had adofovir, we had lamivudine. Lamivudine actually had come for hepatitis B before it was used for HIV. So lamivudine is a very good drug, but it has a low genetic barrier. So resistance to this drug is known if adherence is not good. And adofovir now it is not at all available because it was the resistance was found to this. Then PEG interferon alpha, which we tried for COVID infection also, but it is very costly and it is not cost effective. So nowadays it is not recommended, and it is not recommended as per National Viral Hepatitis Control Program guidelines. We have 3 drugs with us. One is tenofovir, another is tenofovir alafenamide, which is a prodrug of tenofovir, and entecavir. So entecavir is now new drug. It's not actually new. It is available since 2006, but it is freely available in India and now under this program since 2018. So what are the doses of these drugs? So as per National Viral Hepatitis Control Program, we are giving a tenofovir fumarate 300 milligram once a day, entecavir 0.5 milligram once a day for those patients who have compensated or they just have liver cirrhosis and they are not exposed to lamivudine. If patient is exposed to lamivudine, such patient should not receive entecavir because they already have resistance and these patients are not likely to respond to entecavir. So patients of liver cirrhosis should receive entecavir 0.5 milligram. Those patients who have liver cirrhosis with decompensated liver disease, that means ascites and all what we have seen, they should receive 1 milligram once a day. Those patients who have bone abnormalities or renal toxicity, they usually do not tolerate tenofovir because tenofovir has toxicities on bone and kidney. So in those cases, tenofovir alafenamide is available. It is available at it is very means the cost-effective drug, and nowadays it is available at free of cost with us. And the dose of tenofovir alafenamide is 25 milligram once a day. If a child comes with hepatitis B surface antigen infection, how we should approach that child? If child is more than 12 years of age, then 300 milligrams of tenofovir is given. If patient is between 2 years to 12 years, then entecavir is the preferred drug, and depending upon the body weight, dose of entecavir is adjusted. So, and I have already discussed this, that entecavir is not recommended in pregnancy. It is also not given if patient is exposed to lamivudine, and it is recommended and it is drug of choice for children who are aged between 2 to 11 years of age. So entecavir, other than children population, entecavir is preferred over tenofovir in those who are above 60 years of age. So we will be using it in geriatric population. Those who are having bone disease or who are likely to develop bone disease, who have history of fragility fractures or osteoporosis, those who have eGFR less than 60 or have kidney disease or proteinuria, they should not be given tenofovir. They should be given entecavir. Patients on hemodialysis should receive entecavir. So TAF, I have already mentioned that the dose is 25 milligram once a day, and it is used in patients who are having bone abnormalities and renal toxicities. So once we have started patient on this regimen, it is very important. It is just like HIV patients that they have to take lifelong treatment, and adherence required for these drugs is 100% because it's a virus, and if drug levels or the blood levels of these drugs are below the detection level, then resistance to these drugs is known. And at present, we have only two good choices, that is tenofovir and entecavir. So monitoring of these cases regularly, that is the reason why we have peer counselor or peer supporter with us who will be calling these patients every monthly and will find out whether these patients are taking medicines regularly or not. And we are entering this on portal also. So we are trying to keep all the possibilities of non-adherence and taking care of every possibility. So to summarize, that patient with acute hepatitis B usually do not need treatment, but there are few certain conditions. If patient has very high viral load, and it's a controversial, few of the institutes, they recommend that treatment, but as per National Viral Hepatitis Control Program, acute hepatitis patients are not treated with antiviral agents. So it is very important to find out whether patient has chronic hepatitis or cirrhosis, and if cirrhosis is there, whether it is compensated or decompensated cirrhosis. So those with cirrhosis should receive antiviral agents. Those who have chronic HBV infection but they do not have liver cirrhosis should be followed up regularly, and should be the hepatitis B viral DNA load or viral load should be done regularly in such patients. Once the antiviral agents are started, treatment is lifelong, and they should be having 100% adherence to this medication. All patients should be screened for hepatocellular carcinoma and should be monitored. So ultrasonography of these patients should be done at least yearly or in 2 years if patient has all the normal parameters. Now I'll just go through few cases. We have time. I'll spend 5 to 7 minutes on case presentation. Coming to first case, is a 52-year-old male who is planned for laparoscopic cholecystectomy. So as we all know, we detect incidental detection of hepatitis B and C is known. Patient is HBsAg positive. There is no previous history of hospitalization or addiction, and on examination, he doesn't have any positive findings. Hemoglobin is 11.8, platelets are 98,000, bilirubin is 1.2, albumin is 3.4, HGPT is raised, it is 66, and HGOT is 98, prothrombin time is 1.6, patient's viral load is 1,120 copies. Ultrasonography abdomen suggests coarse echo texture. Patient that suggests that patient has liver cirrhosis. Portal vein diameter is slightly raised 14 millimeters. Normally we consider it as 12 millimeters. Splenomegaly is there, but there is no ascites. So what does this suggest? This suggests that patient's liver functions are abnormal, but patient has low platelet count, that is 98,000. So we'll just go to APRI and we'll see how much is APRI of this patient. On ultrasonography, patient shows liver cirrhosis but doesn't have ascites. that suggests that patient has cirrhosis, but it is compensated cirrhosis. So how will we approach this case? So first we will find out what is the stage of liver disease. Cirrhosis is there or not? Yes, this patient has cirrhosis. Because this patient doesn't have ascites, it is compensated cirrhosis. So should we treat? Treatment is recommended or not? And if treatment is recommended, which drug we should start and how long we should treat this case. So stage of diseases, APRI is coming around 2.5. So as per our protocol, APRI is more than 2. So this patient has liver cirrhosis, which is compensated. So patient's HBV is detectable, but copies are less than 2000. So should we give this patient treatment? Yes, definitely, because patient has liver cirrhosis and the protocol is if patient has liver cirrhosis, patient should receive treatment. Now, this patient is started on entecavir 0.5 milligram because he has compensated cirrhosis. I had mentioned that if patient has decompensated cirrhosis, dose of entecavir is 1 milligram per day. Monitoring of this patient is definitely required, and it should be for decompensation. If patient develops decompensation, dose of entecavir has to be increased and lifelong treatment is to be given. So what is the take-home message from this case? Cirrhosis must be looked for in all hepatitis B surface antigen positive patients. In patients with cirrhosis and detectable HBV DNA, antiviral drugs should be started. Serum SGPT or ALT level has no role in deciding need of treatment in such cases. Already those who have cirrhosis, irrespective of SGPT level, we will be starting that patient on antiviral agents. So it should be continued for lifelong. Entecavir is preferred over tenofovir because tenofovir has renal toxicities. And usual dose of entecavir is 0.5 milligram in compensated, and it should be 1 milligram once patient goes into decompensated phase. Coming to second case, patient is 25-year-old woman. She has HbA1c positive report. She is asymptomatic. She is in good health. She did not give any history of previous hospitalization or any comorbidity or any addictions. On examination, doesn't have any positive finding. So, how will we approach her? So, getting her baseline test done, hemoglobin, platelet count, bilirubin, albumin, SGPT, SGOT, prothrombin time, all these tests are normal. But her hepatitis B viral load is 8,000 copies. On ultrasonography, she has normal liver, portal vein diameter is normal, 10 millimeters of mercury, doesn't have ascites or spleen is normal. Now, what is the stage of disease? Does she have cirrhosis? No, she doesn't have cirrhosis. She is almost having APRI is normal. There is no cirrhosis, so she has normal liver functions at present. Only abnormality is she has detectable viral load in her body and the load is around 8,000 copies. So will she need treatment? What our protocol says that if SGPT, SGOT is normal, then we usually do not start. But the second protocol, what we had seen, that we get HBeAg done of these cases. So this patient is ideal candidate for hepatitis B envelope antigen. Her age is 25 years. She is likely to worsen her liver functions. So if hepatitis B envelope antigen is positive and patient, you can see that patient can give good adherence, 100% adherence, patient is approachable, such patient can be started on treatment if HBe levels are positive. So what is take home message? If patient is young, doesn't have cirrhosis, she doesn't need any treatment. Coming to case 3, she is a 38-year-old woman. she was incidentally detected to have hepatitis B surface antigen positive when she was being screened for infertility. There is no history of previous hospitalization or admissions, and examination is unremarkable. So, on her investigations, hemoglobin, platelets, bilirubin, albumin are normal. HGPT, if you can see, is slightly raised. It is 76 international units per liter. HGOT is also slightly raised. Her INR is 1.2. HBV DNA is 1,23,000. So definitely, as we saw that if patient has abnormal liver function test and very high viral load more than 20,000, such patient should receive antiviral agents. So, what is the stage of disease? Stage is APRI is 0.6. There is no cirrhosis. Is treatment recommended? Patient's HBV DNA copies are very high. HGPT is also high. So, this patient can be started on tenofovir once a day, but this patient should be monitored for bone mineral density and EGFR. If EGFR goes less than 60, this patient should be switched over to tenofovir alafenamide 25 mg once a day or entecavir as per the indications what we discussed. So monitoring for drug toxicities and liver cancer is very important in these cases. So what is take home message from case 3? Patients with hepatitis B infection who have high HGPT and high viral load need treatment, need to be started on antiviral agents. In absence of cirrhosis, either tenofovir or entecavir can be used because this patient is young and does not have all or have all renal parameters normal. Tenofovir can be given at this stage because if she develops resistance to tenofovir, we have another option of entecavir to this patient. So these 3 cases can give us overall or make it clear that which patient should receive treatment and which patient should not be given treatment. Now coming to special population, that is hepatitis B virus and hepatitis or HIV co-infection. It is very common. We have at present we have detected 160 hepatitis B positive patients, and out of these 108 patients are HIV HBV co-infection cases. So what is the outcome of this co-infection? These patients usually have more rapid progression to cirrhosis. They have high risk for hepatocellular carcinoma. They usually have higher liver-related mortality, and they usually have decreased treatment response. And if these patients have already received lamivudine or tenofovir, the chances of having resistance is high, and this patient should be closely monitored. So, what we should remember or keep in mind that cross resistance between HIV and HBV drugs is known. There is increased risk of liver injury is more in these cases, and severe liver injury may lead to fulminant hepatitis and death in these co-infection patients. So what are the drug choices? If patient is on tenofovir lamivudine, both these drugs are HIV HBV responding drugs. So if a patient of HIV comes and we get HBV done, hepatitis B virus is positive, we start these patients on tenofovir with lamivudine so that both these infections can be treated. Now we have few cases. We have 53 cases with us who have abnormal viral load because they are already receiving tenofovir. Few of them have already received lamivudine, but their viral load is uncontrolled. Now what are we going to do with these cases? So we have already started few of these cases on entecavir. So we have got their viral load done. If their viral load is suppressed, we will be continue with tenofovir lamivudine. If their viral load is not suppressed, we will start these patients on emtricitabine. So these are the regimens which are followed in cases of HBV and HIV co-infection. Now, another population is hepatitis B and hepatitis C co-infection. Indications for treatment of HBV infection is such patients are similar. Both should be treated. HBV antiviral agents are not effective against HCV virus. So, both should be treated separately. And those who have hepatitis C infection should be treated. Every patient of hepatitis C virus positive report should be treated for HCV. HBV should be treated as per the guidelines what we discussed. So HCV treatment should be started immediately if patient is having co-infection. Now children and adolescent, I have already mentioned, I'll just make it clearer that entecavir is approved for children above 2 years up to 11 years of age. Tenofovir is approved for children above 12 years of age. So this should be remembered. Now pregnant women, we have already seen that entecavir is not recommended in pregnant women. So we have only choice of tenofovir or lamivudine. Tenofovir is a very good drug nowadays. Lamivudine is not at all recommended in hepatitis B virus infection treatment. It is indicated only if patient has HIV infection. So, if there is no recommendation on routine use of antiviral therapy, patient should be considered for anti-HBV therapy as per the protocol what we will be following for adults. So, all infants born to pregnant women should receive birth dose of hepatitis B vaccine and hepatitis B immunoglobulin. And I'm happy to inform you all that we have HBV IG available with us. We have 70 vials with us so that we can prevent HBV infection and mother to child transmission of HBV infection. You all can inform your colleagues or obstetric colleagues that HBV is available in JMC Aurangabad and can get benefit, patients can benefit of this HBV IG, which is available at free of cost. It is also available for post-exposure prophylaxis patients. So if any healthcare worker is getting exposed to HBV and is not aware of antibody titer or has high risk exposure, then these patients can be given HBV IG and it is available with us at present. Now, only few slides, only 5 minutes I will spend on HCV and then we all will discuss about today's topics. So, hepatitis C virus infection, again we need to find out whether it is acute or chronic. As we have already seen that 70% of these cases, they remain undiagnosed and they come with, they just get incidental detection during blood transfusions or some medical procedures. So if patient has hepatitis C positive, report with us, get HCV viral load done. We have HCV viral load test kits with us and our microbiology department is doing HBV viral load, HCV viral load and all the other tests which are required for starting these patients on medication. So if patient gives history of recent jaundice and very high bilirubin, it might suggest that patient has acute HCV infection. So depending upon the viral load, if patient has hepatitis C positivity, viral load should be done. If viral load is detected, patient has HCV active infection. If viral load is not detected, patient is not having HCV infection. So who should be treated if HCV report is positive? Then any individual diagnosed to have infection with hepatitis C viral and viremia. As I said, if HBV viral load is positive, then this patient should be started on treatment. So why HCV infection is treated? Because it is 100% curable. If these patients they develop, have a viremia, we have seen 4 of our cases. At present we have 11 hepatitis C virus positive cases. Out of these 4 cases are HIV, HBV, HCV co-infection, and 2 patients. One patient is geriatric. One patient was pregnant female. So these patients should be treated for 12 weeks. Delay in diagnosis of or delay in treatment for HCV infection leads to cirrhosis of these patients, and if cirrhosis worsens, HCC chances of hepatocellular carcinoma are very high. If we treat these cases, they have improved quality of life, they have long-term survival, and potentially reduce further transmission of HCV. So it is important to treat these cases. So once patient hepatitis patient is HCV positive, RNA test should be done. RNA level is negative or there is no viremia, patient doesn't need any treatment, should be followed up. Patient's viral load should be done after 3 months. If patient has viremia and patient's age is more than 18 years age, patient should be treated. Those patients more than 18 years of age and having HCV, look for APRI. If APRI is more than 2, that suggests liver cirrhosis, then find out whether it is compensated or decompensated. If patient doesn't have cirrhosis, start these patients on sofosbuvir and declatazavir for 12 weeks. So patient is HCV positive, patient doesn't have cirrhosis, start this patient on treatment. If patient has cirrhosis, see whether patient has compensated or decompensated cirrhosis. If it is compensated cirrhosis, give sofosbuvir and velpatasvir for 12 weeks. And if it is decompensated, same regimen along with ribavirin is to be given for 24 weeks. And all these drugs, sofosbuvir, declatazavir, velpatasvir and sofosbuvir combination and ribavirin are available with GMC Aurangabad, and we are treating HCV patients at present. So again, we are keeping this printout in our OPD so that we can stage this patient. If patient has doesn't have cirrhosis, that is regimen 1. Only sofosbuvir with declatazavir is given for 84 days, that is 12 weeks. And then patient is followed up every 3 months. If patient remains viral load free, then that patient is declared as HCV, is cured of HCV. If patient has cirrhosis but childhood score of A, these patients should receive velpatasvir along with sofosbuvir for 12 weeks. If as per regimen 2, if patient has cirrhosis with decompensation, as per regimen 3, patient should receive treatment for 12 weeks. And if it is decompensated, ribavirin should be added. So the doses are 400 mg once a day for sofosbuvir. Declatazavir is 60 mg once a day. We have this combination, sofosbuvir and velpatasvir, that is 400 and 100 mg once a day. Ribavirin is available, but only decompensated patients require this. We have it with us, and if you have any patient who is having decompensated HCV infection, please send them to receive these drugs. You can follow up these patients in your OPD. You can just send these patients for treatment or receiving drugs to us. So the take-home message is prevention is better than cure. Hepatitis C is 100% curable, and hepatitis B and C both are 100% preventable. Thank you very much. I thank Dr. Patne sir for giving me and GMC Aurangabad this opportunity to present this to our esteemed Physicians Association Aurangabad. Thank you, sir. Sir, your mic is unmuted.
Madam, on behalf of Physicians Association Aurangabad, I thank the Dean GMC and I also thank Bhattacharya Madam for taking efforts to educate us on this least known or rather least studied topic, but it's a big scope. Madam, I have a question. The cost of Sobusphere is prohibitively high, as I believe.
Yes.
So we have programs for ART.
Yes.
Likewise, do we have programs for Sobusphere also?
Yes, sir. Yes, sir. As I told, we have every drug is available with us. We have regimen 1, regimen 2, and regimen 3. So we have Sofosbuvir. All the antivirals which I mentioned are available at free of cost. And as I said that you all can continue follow-up of these patients with you all. You can send these patients for treatment to GMC and they will get all these drugs at free of cost. They will get vaccine at free of cost. Your healthcare workers can get it at free of cost. HBV, IG is available, and all drugs, tenofovir, entecavir, and all anti-HCV drugs are available with us. Just like ART program.
Thank you. Is there any fixed day for OPD for these patients, madam?
Thank you, sir, for asking this question. I forgot to mention, you can send this patient daily to OPD number 136 or on Thursday you can send patient. Dr. Sitaram Sabne is our assistant professor and he looks after that hepatitis B cell, and you can send patient to HBV OPD number 136 and patient can be approached and given appropriate guidance and treatment.
Madam, in the capacity of President Physicians Association, can I request you to arrange for a screening test for all my physician members?
For hepatitis, sir, definitely. I will talk to our microbiology department and we will get it done. You just suggest any particular day, sir. I will talk to madam and we will screen all physicians, sir.
Thank you so much, madam. Really, it's a big thing for us physicians. And I thank you all.
Thank you, sir. So, are there any questions? I'll just... Yeah, so we have our dynamic senior most lady physician with us, Dr. Ujjwala Zawar madam. And first of all, on behalf of Physicians Association Aurangabad, let us congratulate her for her recent win and her post as Joint Secretary in IMA and Vice President IMA ladies part. And I request Madam to say a few words.
First of all, I congratulate Professor Meenakshi. She's a born teacher. And she has elaborated the topic so nicely, and she is also very patient friendly. तिचं हे प्रयोजन हे टॉपिक घ्यायचं मला आज समजलं की तिच्याकडे सगळ्या टेस्ट अवेलेबल आहेत, सगळ्या ड्रग्ज अवेलेबल आहेत आणि ते सगळ्या मराठवाड्यातल्या सगळ्या पेशंट्सला युजफुल व्हावे हा तिचा हेतू आहे आणि परत ते व्यवस्थितरित्या. आणि म्हणून आज माझ्या एजच्या माणसाला सुद्धा हे अटेंड करावंसं वाटलं आणि त्याचा मला खूप फायदा होईल आणि औरंगाबादच्या सगळ्या फिजिशियन्सला सुद्धा. दॅट्स ऑल.
She has made all physician friends very proud by being elected for that IMA post. And second thing, madam, as I requested that you are screening our physicians, in later stages, can we screen all the hospital staff of the respective physician friends or the healthcare workers associated with all physicians?
Yes, sir. Sir, I will talk to our Bajaj madam and we will definitely do that. We can make a SOPs for that. That how to select these hospitals and that we both can communicate later and then we will make some SOPs for that. We will talk to Dr. Mrs. Bajaj and then find out some way for that. But we will definitely do that, sir.
Thank you so much.
आता जे मी 1 तास मला लागला तर केस पांढरं होण्याचं किती महत्व असतं की मी जे 1 तास तुम्हाला सांगत होते ते मॅडमने फक्त एका वाक्यात सांगितलं की हे सगळं फ्रीली अवेलेबल झालेलं आहे आणि नाउ माय main objective is that to make you all aware that this is being available at GMC Aurangabad and ही जी काही फॅसिलिटी आज नॅशनल प्रोग्रामच्या मार्फत आपल्याला उपलब्ध करून दिलेली आहे ती आपण पेशंट पर्यंत जर दिली तर हिपॅटायटिस बी चा हा जो
आता आपण एक पेशंट फ्रेंडली पेशंटसाठी अवेअरनेससाठी प्रोग्राम घ्यावा लागेल. कारण की मी एज्युकेटेड लोकांना पाहिलंय की हिपॅटायटिस बी असतं आणि त्याला ट्रीटमेंट लागते, त्याला इन्व्हेस्टिगेशन लागतं. हे त्यांना पटत नाही कारण की ते अवेअर नसतात, त्यांना सिम्पटमलेस असतात. तर मीनाक्षीचा आणि अजून आपण हा प्रोग्राम घेऊ शकतो की पेशंट अवेअरनेस प्रोग्राम
येस
की या हिपॅटायटिस बी साठी सगळ्या टेस्ट किती महत्वाच्या आहेत, ट्रीटमेंट घेणं किती महत्वाचं आहे.
Madam, educated patients मध्ये काय होतं, hepatitis B, either they are unaware or if they become aware, they start panicking. So
Yes.
they need such scientific counseling. Number one. Number two, madam, hepatitis C बद्दल, hepatitis B तरी ऐकल्या लोकांनी, C बद्दल awareness खरंच फार कमी आहे. My son was studying in Dubai and there he sent me 4 patients because the cost of Sobisfir there was very, very prohibitively high. So he sent 4 patients. He said, you arrange for that treatment here. Unfortunately, I was knowing very less about Sobisfir, so I referred them to a gastroenterologist, and I don't know what happened further.
Okay, sir, we are tracing all the cases. We are trying to detect and trace all these cases. So जसं मी म्हटलं की जसं आपण कोविड मध्ये केलं होतं की टेस्ट, ट्रेस, ट्रॅक आणि ट्रीट, तर ते सेम आपण फॉलो करूयात औरंगाबाद मध्ये. आता आज आपण फिजिशियन्स मध्ये केलंय. मॅडम IMA व्हाईस प्रेसिडेंट आहेत. आपण
Physician and IMA vice president.
Madam can be a very good spokesperson for this particular program for Aurangabad. आणि जितके जास्त पेशंटला आपण फायदा करून देऊ शकतो. आणि जसं तुम्ही म्हटलात सर, हेल्थ केअर वर्कर, तर हेपॅटायटिस C व्हायरस खरंच अनडिटेक्टेड आहे. आणि जर आपण हे स्क्रीनिंग सुरू केलं तर डेफिनेटली आपण काहीतरी करू शकू. तर आमचं जे GMC औरंगाबादचा कम्युनिटी मेडिसिन डिपार्टमेंट आहे, मायक्रो डिपार्टमेंट आहे आणि आमचं डिपार्टमेंट, आपण सगळे मिळून हे डिसाईड करूयात आणि वी विल ट्राय टू स्क्रीन मॅक्सिमम नंबर ऑफ हेल्थ केअर वर्कर्स, डॉक्टर्स अँड पेशंट्स ऑल्सो अँड हाय रिस्क पॉप्युलेशन ऑल्सो.
मॅडम, इंडियन स्टडीज काही आहेत का की याचा इन्सिडन्स रुरल मध्ये जास्त आहे, अर्बन मध्ये कमी आहे, असे काही स्टडीज आहेत का?
सर असं अजूनपर्यंत नाही झालं सर. आता मी जे 2018 मध्ये हा प्रोग्राम आला, 19 मध्ये आमचे ट्रेनिंग चालू होते, 20 आणि 21 आपला पूर्ण कोविड मध्ये गेला. आता म्हणजे मी असं म्हणतेय सध्या की मी आता होश मध्ये आलेली आहे. सो आता आपण सुरुवात केली, तर जेव्हा मी सुरुवात केली 3 महिन्यापासून, तेव्हा माझ्या लक्षात आलं की आज GMC औरंगाबाद मध्ये ऑलरेडी 160 पेशंट्स जे आम्ही HIV आणि बाकी सगळ्यांना थोडंसं अग्रेसिव्ह स्क्रीनिंग करून आम्ही त्यांचा डेटा तयार करू शकलो. तर HIVच्या पेशंट्स मध्ये जे ऑलरेडी अँटीरेट्रोव्हायरल थेरपीवरती आहेत, त्यांचं जेव्हा आम्ही स्क्रीनिंग करून घेतलं, कारण HBVची टेस्ट आधी अवेलेबल नव्हती. सो नॅशनल व्हायरल हिपॅटायटिस कंट्रोल प्रोग्रामच्या अंडर टेस्ट किट्स अवेलेबल झाल्या आणि ह्या टेस्ट किट्स अवेलेबल झाल्यामुळे आम्ही प्रत्येकाचं स्क्रीनिंग करायला लागलो. आणि जेव्हा हे स्क्रीनिंग केलं तेव्हा आमच्या लक्षात आलं की 108 पेशंट हे HIV HBV को इन्फेक्शनने पॉझिटिव्ह आहेत. आम्ही युजली मंथली इयरली कॅम्प करायचो. जेव्हा व्हायरल हिपॅटायटिस डे असायचा त्या दिवशी एक कुठलं तरी आम्हाला स्पॉन्सर जर केलं किट्ससाठी, तर आम्ही 100 पेशंट स्क्रीन करायचो. त्याच्यामध्ये आम्हाला 1 किंवा 2 केसेस सापडल्या होत्या. पण जेव्हा आम्ही 4000 केसेस स्क्रीन करायला लागलो, अजून सगळे झाले नाहीयेत, पण त्याच्यामध्ये आम्हाला 108 केसेस सापडल्या. सो याच्यामधल्या 53 केसेसला आम्ही ऑलरेडी काहीतरी म्हणजे त्यांना ट्रेस केलेलं आहे, त्यांना ट्रीटमेंट्स व्हायरल लोड करून घेतलेलं आहे त्यांचं, आणि किती सप्रेस्ड आहेत, किती नॉन सप्रेस्ड आहेत. सो आम्ही कुठेतरी पुढे गेलेलो आहोत. अँड द सेम थिंग वी विल डू विथ द ॲट अ लार्जर लेवल.
Madam.
Yes, sir.
Madam, is aplastic anemia is one of the complication of hepatitis B?
सर येस, हेपॅटायटिस बीचं जसं मी माझ्या पहिल्या स्लाइडमध्ये मी त्याच्यावर फार डिस्कस केलं नाही, कारण आजचा आपला जो टॉपिक होता तो बेसिकली ट्रीटमेंट पार्ट होता. तर इन्व्हेस्टिगेशन्स मध्ये हेपॅटायटिस बी व्हायरस कॉजेस क्रॉनिक इन्फेक्शन अँड एनी क्रॉनिक व्हायरल इन्फेक्शन कॅन लीड टू पॅनसायटोपेनिया. आणि बऱ्याचदा जे पेशंट पॅनसायटोपेनिया म्हणून प्रेझेंट व्हायचे, पूर्वी आमच्या प्रोटोकॉलमध्ये किंवा अजूनही आमच्या प्रोटोकॉलमध्ये आहे की इफ समवन इज प्रेझेंटिंग विथ पॅनसायटोपेनिया, first we try to find out with common viral infections like hepatitis B, HIV, HCV, आणि मग आम्ही पार्वो व्हायरस वगैरे कडे जातो बोन मॅरो बायोप्सी करून. So yes, definitely.
Madam, you said that prevention is better than cure. Is it there circular that all residents should receive this hepatitis vaccination before they start their work at their department?
Sir, we have not made it compulsory, but we in JMC औरंगाबाद जेवढे काही रेसिडेंट आहेत त्यांना सगळ्यांना आम्ही रिकमेंड केलेलं आहे. आपण त्यांना असं प्रिव्हेंट नाही करू शकत की तुम्ही जॉईन होऊ नका जोवर तुम्ही वॅक्सिन घेत नाही, कारण त्याचे 3 डोसेस आहेत, 0, 1 and 6. तर आम्ही सगळ्या HODs ला रिकमेंड केलं आहे. आम्ही लिस्ट घेतलेली आहे. आम्ही एक वॅक्सिनेशन ओपीडी जी मी मगाशी सांगितलं की 125 नंबरला वॅक्सिनेशन ओपीडी अवेलेबल आहे, तिथे कुणीही जाऊन वॅक्सिनेशन घेऊ शकतं. ऍक्च्युअली ऍज पर नॅशनल व्हायरल हिपॅटायटिस कंट्रोल प्रोग्राम दिस वॉज मेड अवेलेबल ओनली फॉर हेल्थ केअर वर्कर्स. तर आम्ही सगळ्या रेसिडेंट्सला डिपार्टमेंट वाईज तिथे जायला सांगितलं. आम्ही मेट्रन मॅडम बरोबर कम्युनिकेट केलं. मेट्रन मॅडमला सांगितलं की तुमच्या अंडरच्या सगळ्या स्टाफचं वॅक्सिनेशन करून घ्या. पण आम्ही जेव्हा हे सुरू केलं तेव्हा कोविडच्या वॅक्सिनेशनचा बुस्टर डोस आला हेल्थ केअर वर्करसाठी. सो देर वॉज सम हे म्हणून मग आम्ही ते अजून तेवढ्या अग्रेसिव्हली सुरू केलेलं नाहीये. बट वी हॅव गिव्हन ऑप्शन की प्रत्येकाने HPV वॅक्सिनेशन करून घेतलं पाहिजे. वी हॅव नॉट मेड इट मॅन्डेटरी yet, sir.
Madam, as a clinician, I'll be interested in knowing a single parameter which you would like to advise our physician friends. आता सरफेस ई अँटीजन किंवा व्हायरल लोड किंवा LFT आम्ही करतो जनरली, पण व्हायरल लोड ई अँटीजन जनरली आमचे लोक करत नाहीत किंवा पेशंट्स आर नॉट विलिंग. सो कॅन यू टेल मी विच फॅक्टर will guide us to think that this patient is eligible for treatment, like viral load, E antigen, SGPT levels. हे आपण जे 4-5 पॅरामीटर्स घेतो ना, त्यातले सगळेच काही पॉसिबल नाही.
येस सर, थँक्यू सर. ऍक्च्युली जसं आपण त्या प्रेझेंटेशन मध्ये बघितलं की सगळ्यात पहिला मार्कर काय आहे की सिरोसिस आणि ऍप्री. आपल्याकडे प्लेटलेट काउंट तर आपण करतोच. तर ऍप्री जर आपण करून घेतलं आणि ते जर मोर दॅन 2 असेल, पेशंटला सिरोसिसचे सर्व मॅनिफेस्टेशन असतील, तर इररिस्पेक्टिव्ह ऑफ एनी टेस्ट, HBE, व्हायरल लोड, वी कॅन स्टार्ट दिस और वी शुड स्टार्ट दिस पेशंट्स ऑन अँटी HBV ट्रीटमेंट. म्हणून जसं जी सिनेरिओ तुम्ही आता सांगितलेला आहे तो फक्त जर त्या पेशंटला सिरोसिस असेल तरच त्याला सुरू करावं, नाही तर इट इज बेटर. कारण आपण जसं HIV म्हणतो की HIV ला एकदा ट्रीटमेंट सुरू केली की ती आपल्याला लाईफ लॉंग द्यावी लागते. तर जर एखाद्या पेशंटला आपल्याला लाईफ लॉंग ट्रीटमेंट सुरू करायची असेल तर इट इज ऑलवेज बेटर टू फॉलो प्रोटोकॉल. सो म्हणजे आपण असं नाही की जाऊ दे HBV ला 3,000 रुपये लागतात, HEV ला पुन्हा 1,000 रुपये वेगळे लागतील, पण दिस विल बी फॉर सम बेनिफिट. कारण आपल्याला पेशंटचं मॉनिटरिंग नीट करता येणार आहे, आपण पेशंटला प्रॉपरली काउन्सिल करू शकणार आहे, पेशंटचा ऍडिअरन्स आपण चांगला ठेवू शकणार आहे. म्हणून जर पेशंटला सिरोसिस नसेल तर त्यांना, म्हणजे जर सिरोसिस असेल तर तुम्ही सुरू करून टाका ट्रीटमेंट. बट यू शुड लुक आफ्टर मॉनिटरिंग ऑफ दिस पेशंट. यू शुड ऑल्सो लुक आफ्टर 100% adherence of this patient. And those who do not have cirrhosis, please get all the tests required which are mandatory for starting treatment as per the protocol.
बरं, आता असं ऑब्झर्वेशन आहे का की हेपॅटायटिस बी वॅक्सिन बऱ्याच रेसिडेंटला दिलेलंच असतं, कारण पूर्वीपेक्षा अवेअरनेस पेरेंट्सचा इतका झालेला आहे की ते जे फर्स्ट इयरचा वॅक्सिनेशन प्रोग्राम आहे तेव्हाच सुरू करतात. आमच्या काळी बिलकुल हे एवढं अवेअरनेस होता, म्हणून आम्हाला प्रॅक्टिसमध्ये सुद्धा आम्ही फार उशिरा हेपॅटायटिस बी वॅक्सिन घेतलं. पण आता बरेच रेसिडेंट वॅक्सिन घेऊन आलेले सुद्धा असतील.
येस, हो येतात मॅडम. आणि आम्ही बऱ्याचदा असं आमच्या लक्षात आलंय जेव्हा ते पोस्ट एक्सपोजर प्रोफायलॅक्सिस घेऊन येतात आणि मग मी म्हणते की अरे बाबा बुस्टर डोस घेतला होता का, बरोबर 6 महिन्यांनी घेतला का. तर जसं आपण म्हणतो की डॉक्टर्स आर बस पेशंट्स, जर आपण 5 दिवसाचं अँटीबायोटिक दिलं तर म्हणजे वी आर नॉट ॲडिअरंट टू इट. तर सिमिलर थिंग हॅपन्स विथ हेल्थकेअर वर्कर्स ऑल्सो, की 0 डोस घेतलाय, 1 डोस घेतलाय, 6वा डोस विसरूनच गेलो. तर जर 6वा डोस घेतला नसेल तर खूप डिफिकल्ट होतं, कारण तेवढे अँटीबॉडी टायटरची जी लेवल आहे, ऍक्च्युली माझ्याकडे ते एक प्रेझेंटेशन वेगळं आहे पोस्ट एक्सपोजरचं आणि त्याच्यामध्ये मी हे सगळं डिटेल दिलेलं आहे की फर्स्ट डोस नंतर किती टायटर वाढतं, सेकंड डोस नंतर किती टायटर, थर्ड डोस नंतर म्हणजे बुस्टर नंतर कितीपर्यंत टायटर गेलेलं असतं. सो मोर दॅन 10,000 जाण्यासाठी बुस्टर डोस हा खूप महत्वाचा आहे. आणि मोस्ट ऑफ दिस हेल्थकेअर वर्कर्स हॅज नॉट टेकन दिस बुस्टर डोस. म्हणून नॅशनल व्हायरल हिपॅटायटिस कंट्रोल प्रोग्राम मध्ये जसं मेन्शन केलेलं आहे की जर बुस्टर डोस घेतला नसेल तर यू टेक इट ॲट द अर्लिएस्ट, जर विदिन 3 to 6 months असेल तर, आणि जर नाही तर तुम्ही तुमचं टायटर करून घ्या आणि मग तुम्ही बुस्टर डोस घ्या. तर बुस्टर डोस खूप इम्पॉर्टंट आहे मॅडम. आणि बरेचसे लोक म्हणजे जे सगळीकडेच एक्सेप्शन्स असतात आणि त्यांनी प्रॉपर
कोविडमध्ये तर बऱ्याच लोकांचं वॅक्सिनेशन प्रोग्राम खूप फेल्युअर झाला.
नाही, पण वॅक्सिनेटेड असतात. आणि आता जसं इथे आपण सगळ्या रेसिडेंटला फ्री ऑफ कॉस्ट अवेलेबल करून दिले. बऱ्याचदा मध्ये दुकानात जायचं, वॅक्सिन आणायचं, मग ते घ्यायचं, हीच असते. ती पण आम्ही काढून टाकली आहे. ती आमच्या ओपीडीज मध्येच ठेवून दिलेलं आहे. ओपीडी मध्ये आमचं रजिस्टर आहे, तिथे HBVचं ते आमचं कम्युनिटी मेडिसिन डिपार्टमेंटच्या अंडर ते रन होतं आणि ते त्याचं खूप व्यवस्थित सर्व डेटा ठेवत आहेत. तर म्हणजे मे बी आफ्टर 3 months इफ वी मीट, आपण अजून खूप पुढे गेलेलो असू. आणि
आपले सिव्हिल सर्जन्स किंवा हे जे हे आहेत ना, हे डेप्युटी डायरेक्टर सेल सर्व्हिसेसचे, त्यांना मॅन्डेटरी करायचं की त्यांनी जे रुरल एरियाज मध्ये हेल्थ केअर वर्कर्स आहेत, दे हॅव टू प्रोड्यूस अ सर्टिफिकेट दॅट दे आर वॅक्सिनेटेड फॉर दिस, ओनली देन दे कॅन वर्क इन अस. कारण सर्वात जास्त माझ्या माहितीप्रमाणे मॅडम हे म्हणजे नॉन प्रॉपर हँडलिंग ऑफ ब्लड आणि इंजेक्टेबल पिन प्रिक्स, हे त्यांच्याकडे इन्सिडेंस खूप जास्त आहे.
येस सर, हा पॉलिसी डिसिजन आहे. त्याच्यामुळे आता असं पण अवेलेबल झालेलं आहे. आणि जे प्रोग्रामच्या अंडर हेल्थकेअर वर्करसाठी आलेलं आहे हे, तर इट इज नॉट मेड मॅन्डेटरी ऑर कंपल्सरी, बट इट इज रिकमेंडेड टू एव्हरी हेल्थकेअर वर्कर. आणि हा जो प्रोग्राम आहे सर, जसं मी पहिली स्लाइड दाखवली होती ट्रँगल याची, त्याच्यामध्ये जे 3 लेवल्स दाखवले होते, MOT म्हणजे जे ट्रीटमेंट मॉडेल ट्रीटमेंट सेंटर जे की GMC औरंगाबाद आहे, आणि अदर ट्रीटमेंट सेंटर्स जे की डिस्ट्रिक्ट हॉस्पिटल आहे, सिव्हिल हॉस्पिटल्स आहेत, रुरल हॉस्पिटल्स आहेत, इथे सुद्धा आता हे वॅक्सिन्स अवेलेबल झालेले आहेत. ह्या प्रोग्रामच्या अंडर सगळं काही अवेलेबल झालेलं आहे. सो मे बी जे काही ऑब्जेक्टिव्ह आहेत ह्या प्रोग्रामचे, ते आपण प्रोव्हाइड करू शकतो हेल्थकेअर वर्कर्सला.
वॅक्सिन रिझर्वेशन पेरिफेरीला करा, जर इलेक्ट्रिसिटी कंटिन्युअस
मॅडम युजली तसं नाहीये. ऑनलाईन UPS म्हणजे ऑनलाईन हे दिलेले आहेत, कारण वॅक्सिनेशन प्रोग्राम्स रन होत आहेत बरेच वर्षांपासून. सो दॅट इज बीइंग टेकन केअर ऑफ बाय मिनिस्टर, म्हणजे ऑल नॅशनल प्रोग्राम्स. सो युजली काही इश्यू नाहीये त्याचा.
तुमच्या प्रॅक्टिस मध्ये मॅडम तुम्हाला हेपॅटायटिस C किती पेशंट बघितले? म्हणजे
सर आता जेव्हापासून आम्ही पूर्ण स्क्रीनिंग आणि अग्रेसिव्हली डेटा करायला लागलो, तेव्हापासून आम्हाला 11 पेशंट हेपॅटायटिस C चे सापडले सर. 3 महिन्यामध्ये 11 पेशंट सापडले. आणि म्हणजे त्याच्यातले 4 पेशंट जे आहेत ते व्हायरल लोड फ्री आहेत, म्हणजे ते आर क्युअर्ड ऑलरेडी. तर 11 आहेत सर सध्या तरी. आता जसं आता आपल्या सगळ्यांकडून जर स्क्रीनिंग वाढलं आणि आपण जर जास्त डिटेक्ट करू शकलो, तर मे बी पुढच्या 3 महिन्यामध्ये आपण अजून जास्त चांगल्या पद्धतीने याचा प्रिव्हॅलन्स सांगू शकू औरंगाबादमध्ये.
With your support, madam, and with your enthusiasm, I think we'll screen all our physicians. Second stage, we'll screen all healthcare workers associated with our physician friends. Then we can also take over.
Yes. Thank you, sir. Thank you so much. So
थँक यू व्हेरी मच. फारच छान मीनाक्षीने आपल्या अपडेटिंग नॉलेज आणि पेशंट फ्रेंडली प्रोग्राम खूप छान घेतला. त्याच्याबद्दल तिचं अभिनंदन आणि आभार.
थँक्यू मॅडम. थँक्यू सर.
Thank you.
क्लोज डाऊन करायचं सर?
Yeah. Thank you again.
Thank you, sir.
So much.
Our secretary will contact you, madam, regarding vaccination.
Any questions are there? Someone
Our
wants to
secretary.
Dr. Anand Kulkarni, sir, is there?
Yeah, he has logged in and he'll contact you, madam.
Okay, fine. Thank you.
You can ask anybody has questions, any
Okay.
physician.
So there are no questions in chat box also, sir.
Okay. Thank you, madam. Dr. Kulkarni will contact you, madam.
Yeah, thank you, sir.
Thank you so much.
नाही, त्याचं म्हणून काय